Hey AACA OSA study chat members, I thought I'd do a video today because I have a couple of visual aids. Today we're talking about positional therapy for treating OSA or primary snoring. Everything I'm going to talk about today is with the understanding that we're operating from a standpoint of having a diagnosis. I wouldn't recommend any of this without first knowing exactly what the diagnosis of the patient's sleep disorder is. But positional therapy is really not rocket science. Basically, we're just trying to get them to get into a position where they're breathing better. So it might be in the right side, left side. They might be elevated. So I was going to show you a little aid here. Now, there is an actual diagnosis for positional sleep apnea. Positional sleep apnea is usually diagnosed if they're, don't quote me on this, I'm pretty sure, if their supine AHI is reduced by over 50% when they're on their right or left side, and if the AHI on the right or left side is dropped below a 5. So usually those qualifications will equate to a diagnosis of positional sleep apnea. They may not always clarify that, but if you see it, that's kind of the raw data that they use to come to that conclusion. But positional therapy can be used for really any type of sleep disorder if it's going to help them to breathe better. So most commonly, basically, we're just trying to get them off their back onto the right or left side. You can use a tennis ball sewn into a t-shirt, something that's going to make them uncomfortable on their back and make them want to roll over. I find that something like the sleep noodle is very helpful. There's also one called a slumber bump. The noodle here is just basically, it's just a piece of foam in there, and you put it around your waist. Same thing with the slumber bump, except it uses an air bladder. Just put it around your waist, around the chest, and basically anytime somebody rolls over, it's going to be uncomfortable, then they'll want to get back on their side. And I find that to be very, very helpful with those mild cases or primary snoring or positional apnea cases. Again, you don't know if that's all that they would need, and really we're still working with the physician. So when I usually have a situation where I'm using positional therapy as a primary source of treatment, I'll just make that recommendation to the patient and to their physician when I communicate with them in a letter. So I still have them discuss their actual treatment with their physician. Now, if the physician is referring them back to me for oral appliance therapy, we're not getting the results we want, I'll include some positional therapy. One thing that's really helpful if you can get a hold of it is the positional data in their sleep study. Now, sometimes you only get back a summary, and sometimes they don't keep that raw positional data. They don't keep that raw data, I've found. They might just give you, their ODI, AHI, RDI, and that kind of information along with the diagnosis. But if you can get the positional information, I find it's really helpful. That'll help you know if positional therapy is going to be helpful. Sometimes the AHI is the same in any position, but often you will see a pretty vast improvement on the side. So I just have an example here. This is a classic case where positional therapy is going to be beneficial for the patient. Their AHI on their back is 11.1, but on the right it's a 4.9 and 5.7. So again, the combination of these scores would drop that patient down to within normal limits. So this patient, as long as their physician approves of it, positional therapy would be adequate. And then we would retest and make sure that the patient's getting the treatment that they need. One final tip on positional data: when you treat a patient, say with oral appliance therapy, you want to look at that positional data because that AHI may not drop as much as you would think. So let's say you have a patient who's you've initiated treatment with, they have an AHI of 18. If they come back and that AHI is, say, a 16, go back and compare the raw data and the positional data. You may find that their supine, the time that they spent in their supine position, has gone up quite a bit. So it's not uncommon to have a patient who might be in the supine position for 25% of the time, and their AHI is 25, and then they get on oral appliance therapy, and now they're in the supine position like 50 to 60% of the time because now they can breathe. So if you do that, incorporate positional therapy and then retest, and you probably will find that the AHI is going to drop quite a bit. So look at that data, and if you don't get it from the physician or the sleep center, request it, and they can get that for you. So anyway, hope those tips are helpful. If you have any questions, hit me up in WhatsApp. We'll see you later.